Hi everyone. I'm going to resist getting on to what the previous speaker was talking about, save to say that yesterday I spent an hour with one of our local headmasters who's very concerned about the level of anxiety in the pupils in his school, but equally concerned about the level of anxiety in the parents, which seems to be causing it. And I think there's a huge piece of work for us to do, not only with children, but also with parents, to try and make this an improved situation. What I've got to talk about today is something that I'm no expert in, but I've been asked to come as a GP and a commissioner to talk to you about unlocking secure care. So I've talked to some colleagues and used the experience that I've got around this area to try and have a look at it. Personally, something that really impacted me a year or two ago was I heard somebody with lived experience of being in a locked unit for some considerable period of time just make a statement that I thought in retrospect was obvious, but I'd never thought about. What he said was, there is no one that you will find in a secure unit who hasn't had something devastating happen in their family. And I think that really took me up short. And I thought there, if no other reason, is a good reason to treat each person as an individual. So we're looking at unlocking secure care. And I've got to ask the question, it's going to be a tough pathway to climb, but actually, are we also trying to balance on a cliff edge with this particular process? And I just want to look at that for a few minutes and hopefully give some thoughts and some ideas about what might make the situation better in the future. The story starts, well, it doesn't start, but it has a starting point in 2009 with the Bradley Report, which was really a comprehensive report to look at reducing offending and to improve the public health of those who had offended, and to end this revolving door where people tend to go in and out of custody when they're actually mentally ill or they have a learning disability. And the report made something like 80 recommendations, and the consensus from talking to people is nothing much happened. I'm not saying nothing happened, but not as much as generally people felt was needed. So I started to ask myself, what and who is secure care for? Is it for the person, or is it for society, or is it for both? And the answer is it's probably for both. However, it happens in a variety of settings. So it happens in medium secure, low secure, PICUs, and locked rehab. And from talking to people, they say that often there is a lack of a clear definition about which should be used and when, and therefore there's a lack of clarity around how we commission those, because the commissioners equally don't have that degree of clarity that allows these facilities to be used effectively. And then PICUs have changed as well. If you talk to people who work in them, their view is that 10 years ago, it was much more about intensity of care and therapy, whereas now the focus has tended to shift to security. Is that people's experience here and know about it? Anybody disagree with that? Generally, that seems to be the view that is coming across. And that in itself is an issue, because what we're doing is using PICUs to contain rather than to treat. So what is commissioned? We all know about the hot potato of Section 136, and in London there's a lot of work going on around this, as there is in other areas, to make sure they're handled better. And actually Section 136 should not be overused, but used judiciously. I don't want to get sidetracked onto that, but it's one area. Another area is Section 117s, and there's really recently been, I think it was the BBC did a Freedom of Information piece looking at the use of Section 117s and saying that there seems to be less money being spent on these when people come out of the units. And part of that is the disintegration of social care with mental health. Many local authorities are withdrawing their social workers from the integrated teams and running separately, and generally the personal experience of patients is that they're getting less than they used to. So, who's it for? Is it for the system so that we make sure that people are all right, or are we really trying to remember that it's that individual who's had some horrendous things happen in the background that we need to be helping and trying to rehabilitate? I know that's oversimplifying it, but I think it's an important question that we ask. Is it an overgrown path? There may be a pathway. How much trodden is it? One or two comments about this. It would seem that there are huge transfer times, particularly for prisoners, to end up in medium or low secure or PICU, and that can be from a month to very, very many months. PICU's average is around 20 to 30 days, but for the other units, it's a lot longer. And it's reported that individuals can have 5, 6, or 7 assessments in that process. If you've had one assessment, that's one assessment too many, I find. It's really soul-destroying when you go through the same process over and over again. And the message is that we need to better connect acute general services and PICUs to the criminal justice system, because at the moment there's a disconnect that allows this pathway to get overgrown because it's so difficult to traverse that people don't get through it. And this is not a criticism of individuals, this is just recognizing where the system is at. That in turn leads to some difficulties with commissioning. We've already spoke about the lack of definition for these various units. And if there's a lack of definition, there's a difficulty in how they're used. And one of the messages that I've had back is if you take what each individual unit thinks they're for and what they do, and you overlay them, there isn't a lot of difference. And then when you add to that where the funding comes from, and often the urgency of needing a bed 3 days ago, do you recognise that? Often the default is a PICU. So is it any surprise that the use of PICUs has changed? Because that's the easy default position, because the transfer times are less, and also they tend to find it easier to get their beds freed up. Not necessarily the best use of the resources that we've got. Third thing, the pathways out of secure and semi-secure accommodation are not clear. Now, this isn't actually distinct from the problem that we've got with acute general beds, because getting people into accommodation is really difficult when they come out of a mental health unit. Often they've lost the place they had before because the benefits have changed, and now the benefits don't allow them to afford somewhere, and a lot of them are faced with being homeless. Now, when you add to that all the complications of the forensic side, getting people out into the community to have community support, they really do need some accommodation they could do to be helped to get back into employment. But those things aren't always there. So what's happening is the beds are getting a bit clogged up because people aren't moving through them as well as they should. Final point I want to make is that the services in the community aren't being developed. Now, that's partly because not too many people are coming out to use them, but equally, the way that people are managed tends to be uniprofessional in secure units. That's very distinct from a lot of areas in mental health. And I think one of the messages I've been getting from people who work in this is you really do need a multidisciplinary case management system, particularly when they're moving out into the community, because many of the problems they're facing, the difficulties, are around social, cultural, and non-medical issues. So we perhaps need to consider putting much more value on non-doctors and non-nurses getting together to manage people who've been in a locked unit through the pathway that progresses them into the community, because otherwise we end up with a medical model which does not work when you get back into the community, where the medical side is actually the least important. And these seem to be some of the issues that are coming up with secure care. So who holds the keys and who carries the can? Because one of the things that makes this a cliff edge is people are anxious about what will happen if things go wrong. Does it go wrong often? No. But when it goes wrong, it can often be pretty devastating. We all know about homicides and other things that have been committed by people who've left secure care. But the issue is that's not frequent, but when it happens, boy, do you feel on the rack. So, we've got NOMS and the Ministry of Justice who make decisions about detention. We've got mental health tribunals who make many pathway decisions. And often they go with the decision of the clinician, the judgment of the clinician. But if it goes wrong, the message I'm getting is they're no longer around. It's left to the clinician. So what does that do to the clinician's opinion and the judgment that they need to make if they know they're going to carry the can? It tends to make them fairly risk averse. So what do we need? We need multidisciplinary teams across the pathway that share the decision making and the responsibility, so it doesn't land on one person's shoulders that makes them feel that they're on a cliff edge, that if the least bit goes wrong, they're going to be tumbling off, and actually there's not going to be anybody at the bottom to catch them. That needs a lot more attention to having a timely approach to the movement of people through this pathway so that it's done effectively. And multidisciplinary teams seem to be a key thing that is not as much in prominence as it should be in this whole system. And then the final question is, who cares? Does anybody really care about these people? There's a lot of a societal view that, oh, lock him up and lose the key, they're a problem in society. But actually, let me come back to that one person who spoke. There's usually good cause for some of the things they're doing. Maybe not an excuse, but there is explanation that we need to take account of and endeavour to help with. So why is it all falling between, or perhaps I should say failing between many groups? Well, commissioning is fractured, isn't it? I've just listed 4 up there: NHS England, criminal justice system, CCGs, local authorities. There's probably others there that we could add. How are we making sure that this is a coherent commissioning system that takes people from maybe prison or from the society through secure units and back into the community again in a secure way, in a safe way, but equally in a way that doesn't get interrupted and facilitates them getting back to some normality? The message is from prisons that prisoners often have to wait until the shit hits the fan before any action's taken. They're only referred to mental health services at the point of crisis. Now, when things are in crisis, when do things need to be done? Yesterday. So where do you find a bed? Wherever you can. Does that make for good decision making? No, as we've already seen, we need to look at that. People say there's a lack of secure beds. Yes, there's a lack of availability of secure beds. My question is that because they aren't there, or because we're not freeing them by making the path back into the community as appropriate and easy as it should be? And we've already talked about risk aversion because responsibility tends to sit with individuals. So just a few things that might make a difference. Shared decision making by multidisciplinary teams across a pathway with shared responsibility is important. Better use of court diversion and liaison services. For example, Section 137 at the moment have to go to a secure unit, but the question is raised, why can't some of them go to a general acute ward if they're appropriate? Early access and referral to mental health input for those in prisons, with better links to general acute services and community services. At the moment, prison transfer insists on going to a secure unit. Is that always necessary? It's kind of one of those things that is better done with a proper assessment. Improved community support, we've already talked about, with accommodation, employment. We need to look at the new models of care where providers are getting together to take the budget for commissioning, but they need to link their Tier 4 budgets with what the area is doing in terms of community and all the other things, because if we don't join up those pathways, it won't work any better. And finally, STPs, Sustainability and Transformation Partnerships, can no longer ignore Tier 4 services, but need to grasp that nettle of joining the pathways up across the footprint so that they are effective and allow people to get the most appropriate care. And you'll be relieved to know I've finished. Thank you for listening.